Hi, can you, sorry, it's coming on a different, okay. Can you see the screen, team?
Yes, yes.
Thank you very much to Santosh and the AOS team for having me on in this session after an excellent talk. Talk so far. Mine is going to be more down to earth and at the coal face. What do you do when a patient presents? So thyroid eye disease is an autoimmune disease. So before you consider decompression, you need to control all the trigger factors. It's extremely important to get the thyroid functions under control. One of the big triggers in this part of the world is smoking. Try to control that. Associated medical conditions. Obviously, we can't control too much on sudden severe stress like bereavement, loss of job, divorce, etc. We are definitely seeing those as factors in the eye disease. Would you consider decompression in the active disease? Usually not. Only if it's really serious, as described by the various grades, a grading of systems, and imminent risk to vision. If there is evidence of worsening of disease in spite of active management of everything that has been said so far, and obviously the other categories without serious and imminent risk to vision, you'll never consider surgical intervention. In the active disease, if the optic nerve signs are getting worse in spite of active disease, then you definitely need to consider decompression surgery. And the red flags of compressive optic neuropathy: red desaturation, reduced vision, contrast, optic disc. This is usually much later in the disease. And visual field, which we always do in every visit. So if there are visual field defects which are getting worse in spite of treatment, then you would consider going for decompression if necessary. Exposure keratopathy, red flags are suboptimal tear film, poor Bell's phenomenon because of associated motility issues. There are very rarely patients with corneal graft who develop thyroid-related disease. Neurotrophic keratopathy, and poor blink reflex, which I'll show you a case where this really led to quite severe issues with the patient's vision. Hydraulic thyroid eye disease or orbital pressure thyroid related disease give rise to headaches, orbital ache, eyelid edema. They may give some signs of activity, but they're actually not activity, but hydrostatic signs, well described by David Verity and Jeff Rose's paper. And looking at radiological features, orbital apical crowding, and looking at orbital fat prolapse. And we all know that 75% of the thyroid eye disease is usually due to muscle enlargement, and 25% is due to fat cavity enlargement. And you can check the muscle index if it's greater than 70%. These are the ones which cause optic nerve compression. What are the high-risk groups where you need to closely watch them and interfere surgically if necessary? Male definitely if they get eye disease at an older age group, they're definitely at higher risk of things going wrong with their vision. Smokers, diabetes adds a huge problem to their management with steroids and obviously radiotherapy. And if it's rapid progression at onset in spite of all the treatment provided, and the older patient onset is the ones which we worry a lot more. They don't get much proptosis, but their eye disease is more in the posterior orbit with muscle enlargement and crowding of the orbital apex. And any concomitant optic nerve pathology, some of these patients could be vasculopaths with ischemic optic neuropathy, etc. Looking at the non-active disease where you may consider decompression as an option is cosmetic decompression. And when the activity is all died down and the patient has motility issues with proptosis, I don't think many squint surgeons would operate on an eye which is proptose. So they would like you to settle the eyeball first before they'll consider doing squint surgery. And the pseudo activity of hydraulic, which we looked into, And so, well, sometimes you may need to interfere for the uncontrolled intraocular pressure. And even if there is no activity, no hydraulic pressure, some of the patients with expanded orbits do have quite significant chronic pain, which are not controlled by any other means. There are no signs of activity, and decompression may be the only option. But there is something called white eye disease or non-active disease with optic nerve compression. We all have come across this in practices. So these are the patients, which is a well-recognized condition. Again, goes to show that the individual patient, the Rundle curve, the scoring systems may all not be that appropriate for the individual patient sitting in front of you. So in this particular situation, decompression may be the first line of management. Pre-operative workup, if needed, we as was discussed about reactivation of the eye disease, we will always give intravenous steroids perioperative, even if the eye is there is no activity. For a non-active proptosis, we will still do IV steroids and followed up with a long-term oral steroids for up to 4 to 6 weeks in any patient to have any surgery around the eye in a patient with thyroid eye disease. And we use quite a lot of tranexamic acid, which has definitely helped over the last 5 years when we first started using them. Before decompression decision, obviously, we have heard various talks on what all you need to do before you consider taking the patient for surgery. And we have heard some wonderful drugs and etc. But my talk is basically all that has been done, and the patient is sitting in front of you who has not responded or is getting worse in front of your eyes. So decompression only after all the other options have been considered. Surgical environment for the decompression, well before the decompression, what would you do? Anticoagulants need to be controlled, as we all know, for any orbital surgery. And in our practice, we always get the anesthetic team, which we are familiar with. They get an arterial line, and the arterial pressure is maintained during surgery for good reason, because if you want to bleed, you want it during the procedure rather than afterwards. So we do not believe in hypotensive anesthetic for orbital surgery. And at the same time, because of the raised pressure in the orbit before and during the surgery, if you reduce the arterial pressure, there is a higher risk of these patients ending up with worse vision because of vascular problems during procedure. And we use tranexamic acid. We always have a familiar anesthetic team, and we are always available for immediate post-op intervention if necessary. Since tranexamic acid is not that well known in the oculoplastics world, or not widely used as it should be, this is the sort of dose they get at induction of anesthetic. And when we do a medial decompression through the endoscopically, we give an intranasal pack as well of tranexamic acid before the surgery. So this is the sort of solution we use along with Merocel tampon or with the neurosurgical patches. And before you consider, once you have decided all the medical treatment has been done, your immunologist has said, I've done everything I can, doc. Here is the patient. And unfortunately, in UK, we don't have access to teprotumumab. The cost currently quoted on the internet is about $200,000 to $300,000 for a year's supply. I can't see NHS approving it at the present time. So when these patients present to us, if you are going to consider decompression, the CT scan is essential. You want to know the level of cribriform plate, especially when you're doing a medial wall, and you want to know the status of the sinuses, and you want to know the status of the lateral wall anatomy. These are all necessary before you decide to go ahead with a decompression. Would you do fatty decompression or bony decompression? In our practice, which is a tertiary referral practice, is mainly patients who come to us after having had initial treatment elsewhere, and majority of them involve muscle enlargement. A quarter of them are due to fat hypertrophy. And an important test is retropulsion. Even if they are inactive disease, if you retropulse and the eyeball bounces well within the orbit, those patients are going to do well with your decompression. If the retropulsion shows the orbit is very tight and fibrotic, These patients are not going to do well with orbital decompression. And you need to decide before you take the patient to theater what sort of decompression you want to do. All the medical treatment has been done. All the trigger factors have been sorted. Teprotumumab is not available. How do you correct this patient? In our practice, we have access to all the other drugs other than teprotumumab. So they get mycophenolate, azathioprine. We don't use methotrexate. Rituximab, unfortunately, our experience hasn't been that great. Cyclosporin, our experience hasn't been that great. So we have gone back to azathioprine and mycophenolate. So you want to decide number of walls. Retropulsion I already mentioned. Is there optic nerve compression? And the books describe 3 to 4 millimeter per wall decompression. Unfortunately, it doesn't really work in the real world. Retropulsion, if it is soft, they are going to do well. If it's hard, you will need to do more than necessary. And again, you need to decide it's one wall, 2 wall, 3 walls, with or without lateral wall advancement. So we'll go through some cases to give a feel for what's going on. Here is a patient who wasn't thought to have thyroid eye disease, but he was picked up with reduced visual fields. And the referring team decided the visual fields could be due to something else because he didn't have proptosis or an obvious eyelid retraction. Though if you look carefully in the left, maybe there is. So they had an MRI scan of the head and the orbit, and you can see huge muscles in the back pressing on the optic nerve with significant visual field loss, but hardly any proptosis. And you wouldn't say this is severe disease on any scoring system looking at it unless you do the visual fields and vision assessment. So again, the scoring system, grading system is useful for progress one way or the other, but not so useful for the individual patient sitting in front of you. Here is another patient, again treated with IV methylprednisolone, and you can see that it has improved, but not completely. So these are the sort of crowding of the orbital apex, with some of them with very little proptosis. Here is a patient who's had medical treatment, IV methylprednisolone and oral steroids, still has significant proptosis and what looks like an active disease, and she had quite tight orbits. Again, she underwent a decompression on both sides, and you can see not only has the proptosis got better, but the activity is also completely gone. The eye is white and clear.
Dr. Sampath, sorry to interrupt. You have got 2 minutes more.
Right. Okay. I will. Okay. This is another patient with proptosis with mild activity, and again, decompression has completely finished off his activity and is a very happy chappy. Here is a patient with very severe proptosis, needed decompression. There is no way this patient is going to get better with any medical treatment. Here's an interesting patient which I missed, the blink reflex. So she came to us with very tight orbits, diagnosed thyroid eye disease, very little proptosis, upper lid retraction, gave her IV methylprednisolone, and then she developed a corneal ulcer on the right, and then the penny dropped. The corneal surgeons took over and nothing worked, so we had to do a tarsorrhaphy on the right, and fearing the same could happen in the left, I did a small tarsorrhaphy because she didn't have much proptosis, or she was not responding to drugs, and with this, her blink reflex got better, her cornea got better, and she didn't want the tarsorrhaphy to be open. She was quite happy to be left alone like this. With extreme proptosis, there is no way you can't get this eyeball back by simply planning a simple decompression. Here, you need to have a better plan before the surgery. Here, we had to advance the lateral wall really forward. That's the original lateral wall. That's the new lateral wall. That's the lacrimal gland. In extreme proptosis, you have to do this in addition and plan for this. Here's an interesting patient who came to us with significant proptosis on both sides, burnt out myasthenia gravis, no Bell's phenomenon, no ocular movements, completely globes out of the orbit, and huge enlargement of the fat cavities, not an active disease, elderly lady. We did a bilateral decompression, took the lateral wall forward, and since she did not have any Bell's phenomenon, I had to do a tarsorrhaphy, which is accepting defeat as far as an oculoplastic surgeon is concerned. The next patient, what looks like glaucoma, she was seen by the glaucoma team for visual field defect and did not have any proptosis. And this was the defect. And at this point, they referred her across after the scan because it showed some problems in the orbit. And at this point, she didn't have thyroid function abnormality, but had enough elevation of thyroid antibody levels. So she has bilateral medial rectus enlargement with optic nerve compression, but not an active disease, but severe in any classification with significant visual field loss. She had a small medial wall decompression, transcaruncular, and this is a visual field post-op. So individual patient sitting in front of you does not follow the various patterns. Since I've been given a set time, here very advanced diseases which are not going to respond well to medical treatment. Here is a patient with a significant proptosis and conjunctival edema, chemosis with keratinization. Here is a patient who I remember well, was tertiary referral, had a tarsography done elsewhere, poor blink reflex, completely proptose globes with corneal abscess. We gave him IV methylprednisolone, took him straight to theater, did decompression on the right, and then later on the left. And the corneal team managed his cornea beautifully, and you can see how well he has done. So this sort of patient, you have to plan a decompression. He's not going to get better. Just one more slide on cyclosporin. And we burnt our fingers with cyclosporin. We don't use it anymore. Here is a typical patient who had every side effect you can think of from the steroids, from the cyclosporin, and eventually he settled with decompression. I will just go to conclusion.
I'm sorry, your talk is excellent, but because of
possibility of time. Just conclude. In conclusion, orbital decompression is safe and effective as long as you have done everything that is needed to get to that stage. It has to be planned and surgical environment extremely well controlled. In our series, the reactivation was less than 2.5%. So if you plan your patient well, treat them adequately before, and have strict indications for decompression, and give them immunosuppression, even if they are non-active, at the time of surgery, they do well. Thank you.